All right, perfect. So we are recording. So I'm gonna start my presentation here. Share my screen. Okay, so for those of you who do not know me, my name is Starla. I'm a PT. I previously used to work at our Encinitas location up until a couple of weeks ago. I actually moved to Texas. So now I'm helping with some clinical support. I'm helping with acquisitions and range retraining and some stuff like that. So I'm going to be presenting this concussion case study today with Sharon, actually. This is an interesting patient that we got the opportunity to see across kind of two phases of care in terms of his concussion. So it is a pretty cool one. All right, so this patient, when we first started seeing him, he's a 26-year-old male, a professional baseball player who actually has a history of seizure disorder. His mechanism of injury when he sustained his concussion, it was actually obtained from a fall while he was having a seizure, and then he got a concussion during the fall. So I am gonna turn it over to Sharon first so she can kind of talk about what it was like treating him in the initial phase of his injury.
Yeah, hey everybody. So this patient fell in the shower while having a seizure, and a lot of times when we get concussed patients in the clinic, it's because they have delayed recovery. A lot of people recover naturally within a week, but the people who don't seek out further help from vestibular therapy or in physical therapy. So I had a personal passion for concussions. I'm an athletic trainer. It was always a hot topic when I was in school. However, since the 2000s, the protocols have changed so much and research has come a long way. And we treat concussion patients a lot differently than we did in the 2000s. So we know now that rest is not best. There's an acute phase and a chronic phase, even for brain injury. And imaging a lot of times doesn't show anything. It's kind of an invisible injury. So we see athletes, we see military, slips and falls. So this patient was a young athlete, baseball player, and his imaging actually showed hemorrhaging in the brain. So he did have quite the fall, bad injury, did have that bleeding in the brain. So there was a acute phase rest period, but once we got past that, it was time to get him moving. So yeah, between Starla and I, we've seen him through a lot of different phases of this injury, and it was really fun to work with.
Can you just talk about what some of his deficits were in the very beginning, Sharon?
Yep, so he continued to have seizures more frequently, which can happen after head injury. We worked closely with a sports medicine doctor. Actually, my friends at Results know Dr. Sanglambeni. He's been a mentor of mine and of Spine and Sport for many years. So he helped us with our rehab protocols for concussions. And he had vestibular issues, he felt dizzy, he had ocular motor issues, so tracking, which is very important for a baseball player. He was a pitcher, so to see the ball coming at him, we did a lot of eye exercises, ocular motor exercises to train his eyes again. A little bit of balance issues. He had other injuries also, like shoulder pain and things like that. So we incorporated the whole body really into this rehab, even though it's concussion rehab. But in the beginning, he could only tolerate exercises, lower level exercises in the quiet, not bright lights. So we started him more in the clinic, in an eval room, and then slowly over time, exposing him to more stimulus. So brighter lights. In this case, Encinitas happened to be inside of an LA Fitness. So we had our own private area. And essentially we were able to expose him more out in the gym area, busier, people moving. I introduced him to the Brock string, which we can go over that a little bit. I think we might have some pictures, but the Brock string is one of his favorite tools that he continued to do even now, years later. I think this patient was 2017, right, Starla?
Yeah.
So we got him out of the initial healing process before we got into higher level activity. And really he continues now long-term with eye exercises. Really a lot of pitchers do that, but for him it's even more important, still residual side effects even years later.
Yeah. And he was able to return to professional baseball, right, Sharon?
You betcha. Yeah, we treated him a few months, and he was able to return to professional baseball. He was the #1 overseas pitcher, I think, the summer after his injury, after he recovered. So he got back at it and crushed it.
Yeah, awesome. All right, so then fast forward 4 years. At this point, he is no longer playing professionally, but he is working as a baseball coach with a local high school team, and he's a scout for the professional leagues as well. So recently he started to report that he was having an increase in dizziness, and then he was having trouble focusing visually, typically when speaking to someone, which was an interesting one.
Okay.
So those were his 2 big complaints. So looking at him in terms of his presentation most recently in 2021, he still had some of those ocular motor deficits. So convergence was one thing that he had difficulty with. So when we looked at how close he could converge, it wasn't too bad. It was around 6.17 centimeters, which isn't too terrible. We looked for around 6 centimeters, so not too far off there. But what we did notice is that he was demonstrating an exotropia intermittently at near. So that means when he was converging, so when the object is getting closer to the tip of your nose and your eyes are coming together to focus on that object, his right eye would spontaneously just correct and point straight forward, as opposed to continuing to come in to converge to focus on that target in order to create a clear image. He wasn't always able to tell that he was doing this, and it was always the right eye every time. Some other deficits that we noted, VOR cancellation caused an increase in his dizziness that actually reproduced his symptoms. And he had impaired balance on the BEST test as well. So he had impaired balance on a compliant surface with his eyes closed, which, you know, for some people, I might not be overly concerned about that, depending on what their activity level is. But because he is so highly active, you know, a former professional athlete, it was important for him, and he really wanted to work on it. And then one other thing that we noted too is that his symptoms would also be reproduced with rapid head or trunk movements as well. So this picture down here is a picture of exotropia. So you can see that that right eye deviated away from midline. So this looks more like a picture of exotropia at far, but his was exotropia at near. So when the eyes start coming together, then that right eye starts to shift outwards. All right, so what did we do about it? So I treated him 2 times a week for 7 weeks. We actually did have a break in the middle because he got COVID. I was curious to see how he was going to feel once we actually got him back into the clinic, and you know, he was safe to come back in and everything. And he said he was really exhausted, really tired, but didn't really have any increase in symptoms or anything other than that. So we continued on with his treatment after he recovered from COVID, and these are some of the things that we worked on. So like Sharon was saying earlier, we did a lot of convergence exercises. So we started off with some of the simple things. We did some of your classic pin push-ups. So, you know, starting out and then bringing your target closer to your face, making sure that your eyes can properly converge, can come together, and that you can see the clear image as you're doing your pin push-ups. And again, the Brock string was another big thing that we worked on. So these, this black image right here is what the Brock string actually will look like as you're focusing on it. So when you are fully converged, that's when you're looking at the bead that is closest to you. And I'm getting some chats here. I just want to make sure that, okay, get to those questions at the end, Dr. Verna. Yes, he still does have seizures. All right, so these are, so this is what the convergence will look like. So when you're looking at the bead that is closest to you, you should see 1 bead, and then the other beads will be doubled. So you should see 1 green, 2 yellow, and 2 red, and it should form that X pattern right there. When you're focusing on the middle bead, it'll form the X pattern with the bead, with the string crossing at the yellow. And then same thing when you're diverging more, when you're looking at that red bead, the string will cross behind the red bead. So he had the most difficulty with convergence. So he had the most difficulty with getting the string to cross behind the green bead. So some ways that you can work on this with your patient is ask them what they're seeing. So if they say that they can't get one green bead. They keep seeing 2 greens, 2 yellows, 2 reds. Ask them where they see the X on the string. So if the string is crossing between the green and the yellow, that means that they're focusing their eyes too far out. So they're focusing in between the green and the yellow, and they're not actually focusing on the green. So 2 ways that you can help them fix that is tell them to imagine that there's an ant crawling along the string closer to that green bead. And you're gonna slowly watch that ant crawl closer to the green bead until it actually hits the bead, and you should be able to see 1 bead at that point. If that still doesn't work, some people need just a little bit of proprioceptive input, so you can actually touch that green bead as well. And sometimes just that little proprioception from your finger can help you find where your eyes need to focus, and then from there you can work on hold times with actually holding that proper image. He progressed past this pretty quickly, so we were able to make it a little bit more fun, and we did all kinds of stuff. So we did rapid convergence and divergence, so he would rapidly go back and forth between, say, yellow and green or red and green. And then eventually we would make it rapid and random as well. So I would call out colors for him to converge or diverge to, and it would be more of a rapid movement of his eyes. So aside from convergence exercises, we also did a decent amount of habituation stuff too, because this is what he really needed in order to decrease the dizziness with the rotational trunk and head movements. So we found that rapid rotational trunk and head movements were really what reproduced his symptoms. So he noticed it first time when he went to pick up a baseball on the ground and then turned over his shoulder and looked over his shoulder to throw it back to one of his players. And then he was able to reproduce it a couple different times. So we tried to just habituate him to those sorts of movements the best we could. So we actually started off on the back strong with lumbar flexion and then extension and rotation at the same time, which made him pretty dizzy for a little bit. So we started off slower, and then we made it a little bit more of an explosive and a rapid movement. And we added in a lot of cross training as well. So we did some cross body clean and presses where he held a kettlebell, reached down towards the opposite foot, and then brought it up and over his head on the contralateral side, looking at the kettlebell the entire time. So it's that rapid head and trunk movement there. And we really got pretty creative with this sort of stuff. We did some pop squats with a 180-degree turn in the middle. We were catching and throwing over his shoulder. So I would throw it over one shoulder, he would catch it, and then throw it over the other shoulder, and he would rapidly go back and forth like that. Just trying to reproduce what was bringing on his dizziness. And towards the end, we were actually able to push this quite a bit to kind of reproduce what he's doing in practice. All right. And for his balance training, he really wanted to keep practicing on the compliant surface with his eyes closed. So we did a lot of work on the foam with the eyes closed. And we were able to progress to using the Dynadisc and some higher level balance exercises. We added in distractors. We made it more challenging for him by being in the gym in the busier environment. He was one that always liked to avoid being in those busy, loud environments in the beginning. He kind of started to avoid those again. So a little bit of retraining with that. And eventually he was able to be on the Dynadisc, balancing on one leg as I was, throwing balls in kind of random directions and making it random for him. And then the last thing was working on his VOR cancellation. So I like to combine VOR cancellation exercises with other exercises. So we did so VOR cancellation, right, is when you're looking at a target and then you're moving back and forth. So it's the ability of the eyes to focus on one target as there's a moving background, essentially. So with that, I like to combine that with other exercises. So I was having him look at his thumb as he was doing torso rotations at the cable column. We were doing lateral medicine ball tosses and catches as he's watching it the whole time. You can do a side plank with VOR cancellation. We really started to get pretty creative with his program. So after 7 weeks of doing this, he reported that he had decreased episodes of vertigo and he was no longer experiencing any difficulty focusing his vision. His VOMS testing was normal at the end, and he no longer displayed that exotropia where the eye would go out to the side. and he had improved balance as well. Continued to have difficulty with the single leg balance on the foam. So that was one of the things that he really wanted to continue working on as part of his home program. So at this point, we set him up with what he dubbed his Neurofit Plan. So his goal coming into me was, I want to be able to manage this on my own, and I want to know what to be able to do in every sort of situation. So like I was saying when I answered Dr. Verna's question, he did continue to have seizures. At this point, they're maybe like twice a year. They're not as frequent, and they're most often in his sleep actually now. But he was asking, what do I do in these various situations? So I'm going to get out of this presentation. All right, you guys can see my screen still, right? Yeah, okay. All right, so this is the quote unquote Neurofit program. So he went in, made this Google Doc, and asked me to set him up with a program in all of these different situations. So this was his full neurological workout. So I gave him an eye exercise warm up, which is a little bit further down, some balance exercises to work on. So single leg balance on the compliant surface, the Dynadisc, single leg RDLs on foam, all of those rotational movements that we habituated him to. We did a lot of that sort of stuff. Roman chair with the trunk extension, just like we do it on the back strong, the catching, throwing. Really all of his higher level exercises were in the full neuro workout. All
We
right.
still see your PowerPoint, Starla, if you want to switch your screen.
Thank you, Sharon.
Got you.
All right. Can you see it now?
Yep.
Perfect. All right, so this is the Norofit program, as I was saying. So this is the full-on neuro program. Then I gave him a quick 10-minute workout to do, and these were really just the most important ones for him. So I assigned him the Brock string push-ups, the Brock string tracking. So holding the Brock string and kind of moving it back and forth. So being able to keep that convergence with a moving target as well. And then again, some of the single leg balance. I gave him a morning routine. So his 10-minute warm up, a little bit of convergence, and then just some general stretching, and so on and so forth. And then one of the other ones that he really was asking about was a post-seizure program too. So really the goal with that is just some gentle aerobic exercise to improve his energy. So, you know, I really hammered at the point that you don't want to overdo it after a seizure. There's too much neural excitability at that point anyway. So you just want some gentle aerobic activity, walking, biking, whatever feels good. Maybe some of the gentle exercises and stretching. So you can see there's a bunch of different situations in here. And then I gave him some equipment to buy as well, the Dynadisc, the Magic Eye Book, if you've ever seen that, you may have as a kid. So he was really appreciative. And I just want to show you guys one more thing. This is what he said to me at the very end. Thank you for completing the Norofit plan. Really cool. I'm going to use this for the rest of my life. So he was a really fun patient to treat. And I think, you know, he got a lot out of it.
That's awesome.
Yeah, I do see there are things in the chat. And yes, he was on Keppra for his anti-seizure meds.
Yeah, and that's something that's an indicator of delayed recovery, is if they have neurological problems to begin with. A seizure disorder, I remember now he had a history of migraines and family history of migraines. If people have mood disorders, anxiety, depression, even learning disabilities, dyslexia, those are all correlated with delayed recovery after brain injury. Still research being done on that, but we know that they are correlated. So a lot of the people that we see with delayed recovery after head injury have some of these disorders already, even like ocular motor issues. If they have a lazy eye or something going on there, they'll have delayed recovery after concussion.
Sharon,
Yeah.
he had migraines, but not seizures before the concussion, right?
Well, I think so. He had episodes of syncope, he thought. So it could have been a seizure, but he wasn't diagnosed with seizures formally until after the time he fell in the shower. Fainting, seizure, we don't know, but after that, they became more frequent, the seizures.
Okay. So it's interesting, guys. You know, there's more concussions than work comp injuries, so we see quite a bit of that. And the only time you're going to have an impairment is if you're left, and that's why I asked about the seizures. If you're on medication, you're going to be provided a permanent impairment. Even if you take the medication to prevent seizures and you never have a seizure, you have large impairment as an individual because it can affect driving and other things for work comp injury. Sadly enough, you could have hemorrhage in the brain, but if you have no impairment afterwards, in other words, if it doesn't affect you, you have zero impairment. But if you're on medications, you have an automatic impairment.
Starla, what would you say is the most rewarding part about treating patients post-concussion?
I mean, that quote alone says a lot, right? He was so appreciative of what we did. And I think concussions are a scary thing for a lot of people to treat. And it is kind of like a black box, right? You know, it's in PT school, at least where I went, it's briefly touched on in one lab in, you know, a class. You know, it's not really elaborated on very much. So I think kind of getting over that fear factor and maybe doing some continuing education courses to further the education there and then kind of diving into the treatment. It's not as scary as it seems, and it is super rewarding when you're actually able to change their quality of life.
Awesome. And if anyone else has questions, you can unmute yourself or use the chat if you like. I mean, during the acute phase after concussion, there are phases similar to a lot of rehab that we do, acute and subacute. But it has to do with stimulus. It has to do with physical exertion, even concentration and focus. We build all of that up strategically and monitoring their symptoms the entire time. But I think the biggest thing I learned along the way and why it's so scary for therapists maybe to start treating concussion is that likely, like there's a point where you want to see where their edge is at. They're going to get a headache again. They're going to feel dizzy again. And if it's just a little bit, that's okay. It's like bicep burn when you're doing bicep curls. A little bit's okay, a little bit uncomfortable. You don't want to jump, 8 points on the pain scale or anything or have a new symptom. That's when you backtrack. But it's okay to push these patients in that chronic phase. And that's actually what they need. Back not so long ago, bed rest, dark room, be careful, ooh, don't study, don't read too much. At some point though, in that chronic phase, you push it a little bit and work out the brain just like you would any muscle in your body.
Yeah, definitely. And I think that a big piece of that too is educating the patient on that too. I always tell people, there's not many times where I tell you to push through pain, but this is absolutely one of them. This is not going to be the most comfortable thing that you're ever going to do. You're going to feel worse, but it's one of those things that you have to feel worse to feel better in that chronic phase.
And
did you use the heart rate as a way of monitoring his reception to the exercises still at that point?
When I was treated, go ahead, John.
In the acute phase, when he was in his first 2-3 months of therapy, once we got to the exertional part, because that did bring on dizziness and headache when he would run versus walk. So I used a heart rate monitor. I did a treadmill test, a step test, and I saw where his threshold was, both heart rate and then time. So I worked him up that way too, exertion with getting his heart rate elevated and then prolonged activity, how long could he sustain there? And eventually we got past that part where exercise, just pure exertion, running on a treadmill or on a spin bike, we got past that where that didn't trigger any symptoms anymore. So we kind of graduated from that at that point, and then we don't really have to use a heart rate monitor anymore. He was cleared in that sense, and it was more the oculomotor in the end.
Yeah, and then when I was...
Go ahead.
I was just going to say, when I was seeing him, he was past that phase too. It was more so the habituation exercises. He could work out, full exertion with no symptoms, but when he incorporated some sort of rotation into that full-on workout, that's when his symptoms came on. So we just did habituation when I was treating him.
Yeah, one of the things that I went through, especially in Northern California, learning the different exertional protocols, is that You really have an idea. You're not going to be perfect, but you really want to work also if you can communicate well with a physician that's familiar with concussion, because immediately, who do we always think we look up to with a concussion? Who is the specialist that you would look up to or ask questions? I think the majority of people would say a neurologist, right? You're going to find as many times the neurologists just really want to know if you have a brain injury, severe, that they can operate or they can treat. If that, in that niche of concussions, they look at a concussion, in my opinion, I don't know, Sharon, if you can chime in, they think it's like an orthopedist that gets an ankle sprain. They're not too excited about that. If you do find a neurologist, you have to find one that's passionate about concussion rehab or is up on concussion rehab. The other thing that we found out working through the years, and even with Sharon, is that you're perfect, but you want to see like what's one of the main components of that concussion. Like in this case, Starla was clearly ocular, right?
Yeah.
Sometimes it's vestibular. Sometimes the neck causes a lot of symptoms. They have a lot of weakness in the neck. So if you can ID and you can dissect it a little bit and focus on that, you do really well. And one time remember that kid, Sharon? We tried everything. He was greatly fit. Yes, he got some headaches on exertion, but he really needed more time when he did his math test. And when he did that, he passed that anxiety. All the symptoms went away. So sometimes you need more time with whatever you're doing at school, or the doctor has to titrate medications. So, every concussion is a little bit different.
Yep, if you've seen one concussion, you've seen one concussion. All right, that's about time. Starla, any other questions you want to answer, or you want to wrap it up?
I don't think so. Yeah, I won't keep you guys. I know you have patients and everything. So thank you for coming. And then we are going to post this as well. So if anyone missed it and wanted to access it, it's recorded.
Thanks,
Thank you.
Starla.
All right, guys. Have a good day.
Bye.
Good job, Starla. Good job, guys.
Thanks.